Olá, muito boa tarde a todos. Aqui só confirmar se a doutora Lacerda já me consegue ouvir. Já? Pronto, vamos começar. Pronto, entretanto também temos aqui o Justin a entrar. Hello, Justin. Hi.
Hello.
I'm just introducing the webinar and we'll start right after. Thank you very much for being here.
Yes, thank you.
E a doutora Lacerda também, muito obrigada por estar aqui. E vou começar aqui com a introdução. Boa tarde a todos, estamos aqui mais uma vez para um Conversas Sobre. O Conversas Sobre foi um projeto informativo que lançámos em 2020 e que consiste em sessões temáticas online curtas, direcionadas para as famílias, para os doentes ou também para os sobreviventes, sempre orientadas por profissionais da área. Para estas conversas escolhemos temas que sentimos de serem preocupações dos pais ou assuntos que os possam ajudar de alguma forma. Até ao momento já abordámos a adolescência, os efeitos secundários dos tratamentos, ensaios clínicos, os irmãos, cuidados a ter com a pele. Estas conversas, apesar de serem em direto, estão gravadas e estão disponíveis tanto no nosso site como também no YouTube. Hoje as nossas conversas serão sobre a qualidade de vida e sobre os cuidados paliativos nas crianças e adolescentes com cancro. Desmistificar é o objetivo de hoje. Para isso convidámos o Justin Baker, diretor da área de Quality of Life and Palliative Care de um hospital de referência a nível mundial, o St. Jude's Children's Research Hospital, para conhecermos não só a sua realidade, mas também a sua perspectiva. Convidámos também a doutora Lacerda, pediatra no IPO de Lisboa, mestre em cuidados paliativos e coordenadora de alguns grupos de trabalho de cuidados paliativos pediátricos, quer ao nível nacional como internacional, e que também temos a honra de ter no nosso Conselho de Curadores. Agradeço desde já, já agradeci no início a presença dos dois. Como a apresentação do Justin vai ser feita em inglês, e apesar do Justin já estar aqui connosco, como vocês já viram, para facilitar a compreensão optámos por gravar para que o vídeo tivesse legendado. Depois dessa apresentação, passarei a palavra à doutora Lacerda para que enquadre a realidade dos cuidados paliativos pediátricos aqui em Portugal. E depois das duas exposições, não só do Justin como da doutora Lacerda, teremos um espaço de tempo reservado para responderem a todas as perguntas que tenham. Quem nos acompanha no Zoom, peço que durante a sessão vão colocando as vossas perguntas na área de Q&A, disponível na parte inferior do ecrã, indicando, obviamente, também a quem as querem endereçar. A quem nos segue pelo Facebook também o podem fazer, colocando as vossas perguntas nos comentários. As perguntas podem ser colocadas em português, temos aqui a doutora Ana Lacerda que nos ajudará aqui com a ponte com o Justin. Então, vou passar então a palavra ao Justin, ao vídeo que temos preparado. Justin, I was just saying that now we're going to show the recording that we have you on. So I'll see you in a while. Okay. I'm sorry.
Well, hi, my name is Justin Baker. I'm the Director of Quality of Life and Palliative Care at St. Jude Children's Research Hospital in Memphis, Tennessee. It is such a joy to be with you here today. I'm going to talk to you about when your child has cancer. I'm going to talk about palliative care, and I'm going to talk about compassion, and I'm going to talk about hope. And I think I'm going to probably, hopefully at least, remove some of the stigma around palliative care. As we get started, I need to introduce you to my team. I've got a couple teams, and they're all across this slide here. You can see our koala team, and that stands for Quality of Life for All Kids. And I want you to hear that phrase, quality of life for all. And then down in the bottom left, that's my home-based team. And you can see the koalas are not only in the picture with my other team, but the picture with my home team. And then I want to talk to you about a word that is so vitally important, and that's the word compassion. And compassion is something we're going to talk about throughout this entire talk with you today. Compassion literally means to suffer with. And one of the great privileges of my job as a pediatric oncologist and as a pediatric palliative care doctor is that I get to work compassionately with my patients and families. I get to provide compassionate care to them, which means I literally suffer with my patients and families. So one of the things that we've been talking about is suffering and suffering with and compassion. And suffering is actually the disease that we attend to in palliative care. And many people, when they see this Edward Munch, his picture of Scream, they picture the feelings that may be present here. I got to see it firsthand, and I had many feelings. And as I think about suffering, I love these quotes by Eric Cassell, who's a pioneer in palliative care that died this year. He said, suffering is a specific state of distress that occurs when the intactness of integrity of the person is threatened or disrupted. It lasts until the threat is gone, or the integrity or wholeness of the person is restored. The meanings and the fear are personal and individual, so that even if two patients have the same symptoms, their suffering would be different. And so when we think about suffering, sometimes we think about a framework. And interestingly, it's so vital for us to recognize that suffering happens within the context of a patient and a family. And you can see here there's parents and siblings and the patient. And then you think about the integrity, the word that I just mentioned from Eric Cassell. And it comes where there's visible threats. These visible threats may be coming in the form of things like life-threatening illness or physical symptoms. And then there can be invisible threats where there might be disruptions in normal life, emotional symptoms, existential concerns, socio-demographic concerns. That leads to suffering. And part of our job in palliative care is to think about targeted interventions and global interventions to help the family with their new family integrity. This slide is from Dr. Joanne Wolf and from her team at Dana-Farber, and so grateful for this easy way, this simplistic way of looking at the incredibly complex concept of suffering. We have to realize, as you do, that cancer affects every aspect of life. And when we think about this concept that I'm going to try to talk to you a little bit about now called total suffering, we realize that suffering comes in the form of the cancer management. So if we think about the primary diagnosis, the comorbidities, could be physical, such as pain and other symptoms, and maybe wounds or function. Could be psychological, things like depression, anxiety, emotions, and fears. Social, with cultural values and beliefs and relationships, maybe financial concerns. Spiritual, things like meaning and value, things like existential issues and transcendental components of care. Practical, activities of daily living or caregiving. It certainly could be about end-of-life care, but as you can see, that's a tiny component of what we're talking about. And the reality is that cancer affects every single aspect of life. And so what is palliative care? I talked about total suffering. Well, palliative care is the total care, which improves the quality of life for those with life-limiting illness. It aims at relieving or at least attending to this total suffering or total pain. And that suffering may be physical, emotional, psychological, social, or spiritual. And it's really multidisciplinary, its approach. It needs to be team-based. So we need to think about this in a holistic fashion. So you can't look at any one of these pieces and think, oh, I can take care of all of that. No, no, no. It takes a team. It has to be multidisciplinary. The WHO has stated that palliative care is a holistic approach that improves the quality of life for their families facing the problem associated with life-threatening illness. And it does so through the prevention and relief of suffering by the means of early identification and assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And it's actually been proven to improve quality of life, and it can indeed reduce the overall cost of care. So when you're thinking about palliative care, what I want you to recognize is, as an oncologist, the enemy that I treat is cancer, right? Cancer. As a palliative care doctor, the enemy that I treat is suffering. Exactly, suffering. And so when we think about suffering, we always have this dual goal of, let's fight that disease. Let's make sure that we can do everything we can to treat the cancer. And let's do everything we can to improve quality of life and to make sure that every day is the best day that it can be. And this really is what the World Health Organization has stated. They've stated that acknowledging that palliative care is an ethical responsibility of health systems, and that it's the ethical duty of healthcare professionals to alleviate pain and suffering, whether physical, psychosocial, or spiritual, irrespective of whether the disease or condition can be cured, and that end-of-life care is among the critical components of palliative care, but it's only a small component. And unfortunately, everybody thinks that palliative care is about end-of-life care. It's not. It's about making sure every day is the best day possible. And I feel so fortunate because I got to advocate for this at the United Nations and really try to make sure that palliative care is a component of universal health coverage for all patients and families that are suffering in any form. And so when I think about palliative care, I think about how palliative care needs to be integrated throughout the illness trajectory. It needs to be integrated throughout the institution. In fact, I like to think about this three-tiered model where palliative care is available as needed, like on call. It's integrated into particular teams, and it's also coming out of the pores of the institution, right from the bottom up, where it impacts the entire institution. And that's really what we're talking about with palliative care, that it is integrated throughout the care of every patient, every family whose child is suffering from cancer. And when we think about the tools for providing high quality palliative care, and this is what you're looking for in your clinicians, it's being able to listen. We have to listen so that we can lean into it and really recognize that, wow, as a clinician, that person's listening to me. We have to have a heart that's changed by compassion. We have to be willing to suffer with our patients and families like I talked about, and we have to have this team. And then as we think about palliative care, the other things we advocate for are we advocate for involving the child. So how can we better bring the child into the process? How can we better engage them so that they don't feel like this child might have isolated and abandoned? And then we also have to recognize that communication is the cornerstone of what we do. We have to be able to effectively communicate with families, and you have to be able to effectively communicate with us as clinicians. I want to turn quickly to a resource that's available to you, and this is called together.stjude.org. It's available in Spanish. It's available in Portuguese also. And so you can click on this. You can change the language of this. And so you start at together.stjude.org, and then you can change the language. And there's all sorts of resources for you about cancer, about connecting, about care and support, about diagnosis and treatment, about palliative care. I want to share with you some additional key concepts as you're thinking about your cancer journey and your family. I've said good communication matters, and we're going to talk a little bit more about that. Empathy and compassion are some of our strongest weapons. We have to also understand the goals of care, and that goals of care conversation is one that works out really well when we have that conversation early. The stronger your relationship with your care team, that's better for you, it's better for your child. So make sure to strengthen those relationships. I'm going to talk about how hope is the thing with feathers. I'm going to ask you to let other people help you. Human connection is like a balm. It's like a lotion. It's like a salve. So what's so hard about communication? I have this funny video to share with you, and
well, the Cots and the Tempertones merked the glucoses and overclocked the mergachuses. There's to Vidas Grisabon and part of Isaac is together T mode celebrity and appetity, so fourth frame shows data vision and auditory slow perfection. Resounding friction induces corresponding blip mortalizers, but that all comes under Kroner's electropulmonary certification, which you will underlies in a professor course.
I'm going to move forward from that because I bet that was pretty difficult to subtitle. The reality is, and the problem is, there's lots of communication barriers. And one of it is maybe that we think we're speaking the same language, but just like you were listening to, it may just sound like blah, blah, blah. Unfortunately, we in healthcare are not trained in communication very often, and this is a real problem. And the most common technique to learn communication is trial and error, and that's terrible news. So we have to realize that similar to scalpels for surgeons, words are the palliative care clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words. And so I'm constantly talking to us about how, and talking to other clinicians about how our words matter. Or this St. Jude parent who told us the way you tell the truth matters. And I think about Emily Dickinson and this beautiful poem that is, tell all the truth, but tell it slant, success and circuit lies. Too bright for our infirm delight, the truth's superb surprise. As lightning to the children eased with explanation kind, the truth must dazzle gradually, or every man be blind. And what this means is all of us have different communication needs. We have to realize what is it that works best for us. You have to think about this as a family. What are the ways that we can best connect and communicate with our clinicians? We also have to realize there's extreme power in empathy. And you're going to be journeying through this, not just as your family, but with other families. And I would encourage you that as other people are going through this, one of the ways that you can also heal is by healing with others. And so I'm going to play this video by Brene Brown, and I think it will be meaningful to you.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
What makes something better is connection. And the beauty that we also know is that empathic communication even impacts symptoms. So sometimes simply talking to a compassionate listener can help your child or help you as a family feel like a new person. And what we have to be looking for is this really skillful combination of roles where we're dedicated to discovery and committed to caring, and we're integrating these things right from the beginning, because that's how we know the best outcomes happen. And this is what happens here at St. Jude. And this is Danny Thomas, who started our hospital. And he, right from the beginning, was dedicated to discovery, to cure, and committed to caring, healing, right from the get-go. And when we think about the amazing strength that comes from relationships, this is what we have to be working towards as a community. You as a parent need to be looking for ways that you can strengthen relationships in the middle of this tremendously difficult journey. And if you have a stronger relationship, if you're able to establish this therapeutic alliance with the clinician and with other family members, even with other cancer family members, and you can kind of think about this therapeutic alliance, this strengthening of the relationship, people have actually improved psychosocial outcomes and decreased decisional regret. This is vital to understand, because you guys, as you're going through it, will feel isolated. But if you invest in relationships, including the relationships with clinicians, with palliative care clinicians, your oncology clinicians, you will have decreased decisional regret and improved psychosocial outcomes. That's really exciting. And it really comes down to trust. And trust is about continually feeding the piggy bank, putting in the coins into the piggy bank, making sure that the trust is being built. So when we think about goals of care, this is really important to understand. And it's very important when we think about how do we have a conversation with every single new patient and family as they come through. And what I want to tell you is that as we're thinking about this, we want you to be seen as a person. Tell us about your child as a person. What brings your child joy? What's your understanding of your child's illness? Knowing about their illness, what's most important thing to you right now? What are you hoping for? What are you worried about? What keeps you up at night? Where do you find strength? Is it helping you now? How are you managing day to day? Is there anything else I could know about you that would help me take the very best care of you possible? These are vital questions. And even if clinicians haven't asked you them, you should be thinking about them and you should communicate these to them. And when we think about the goals of care in pediatric oncology, this is a goal of cure, of leaving no stone unturned, of living as long as possible and as well as possible, and focusing on comfort. And as we think about these goals, we also always recognize that these are evolving, because life evolves and medical issues evolve and change. And there's always this dual goal of comfort. Like I said, we're always emphasizing what it is as far as making every single day the best day that it can possibly be. And interestingly, there's lots of factors that weigh in on decision making. We might think about hopes and values and relationships and the child's wishes, and all of these factors lead to the goals. And those goals are what should be driving treatment options and decisions. The beauty of all of this is we also recognize that no matter what goal we're in, it's hope that sustains that goal. As I mentioned, hope is the thing with feathers. We have so many beautiful hopes that we have in this world. And so we ask questions like, what are you hoping for today? And this is a beautiful way to talk to your children. What else are you hoping for? That's so helpful. Tell us what else you're hoping for. And then we can better understand what it is that each day they're hoping for beyond clearly being cured of their illness. What else? What else are we thinking about? What else are we hoping for? So as we begin to wrap up, we've talked so much about suffering. You can see by this last sentence, the relief of suffering and the cure of disease. They have to be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. And what we have to recognize is that communication, acknowledgement, that just if we all recognize the suffering around us, we lead into that, this can lead to connection. And so as we close, I want to begin to share with you this video. And it's a brief video, but I think it's tremendously helpful. And when you're thinking about this, I want to think how you could connect with other people, how you could lean into their suffering, and how you could try to help people realize how they can help you.
So what do we do about all the pain we see in the world? All the pain we feel in our own lives? And why does it seem like our best efforts to help somebody feel better always backfire? I've been studying intense grief and loss, baby death, violent crimes, accidents, suicides, and natural disasters. And I've learned something really interesting. Cheering people up, telling them to be strong and persevere, helping them move on, it doesn't actually work. It's kind of a puzzle. It seems counterintuitive, but the way to help someone feel better is to let them be in pain. This is true for those giant losses and the ordinary everyday ones. Educator Parker Palmer writes, "The human soul doesn't want to be advised or fixed or saved. It simply wants to be witnessed exactly as it is." He's talking about acknowledgement here. Acknowledgement is this really amazing multi-tool. It makes things better even when they can't be made right. For example, somebody's struggling. Their baby died, or there's been a bad accident, or their mom got sick, and they're just sad. It's way more helpful to join them in their pain than it is to cheer them up, but here's what we tend to do instead. "You have 2 other children, you need to find joy in them." Or, "You know what you need? You just need to go out dancing and shake it off." Or, "I felt really sad once. Did you try acupuncture?" We're not really sure what to do with someone's pain, so we do what we've been taught. We look on the bright side. We try to make people feel better. We give them advice. It's not like this is nefarious. I mean, we try to cheer people up because we think that's our job. We're not supposed to let people stay sad. The problem is, you can't heal somebody's pain by trying to take it away from them. Now, acknowledgement does something different. When a giant hole opens up in someone's life, it's actually much more supportive to acknowledge that hole and let pain exist. It's actually a radical act to let things hurt. It goes against what we've been taught. In order to really support you, I have to acknowledge that things really are as bad as they feel to you. If I try to cheer you up, you end up defending yourself and your feelings. If I give you advice, you feel misunderstood instead of supported. And I don't get what I want either, because I wanted you to feel better. It's pretty rare that you could actually talk somebody out of their pain. Rarely does the admonishment to look on the bright side actually heal things for someone. It just makes them stop telling you about their pain. It's so tempting to try to make things better. When somebody shares something painful, it's much more helpful to say, "I'm sorry that's happening. Do you want to tell me about it?" To be able to say, "This hurts," without being talked out of it, that's what helps. Being heard helps. It seems too simple to be of use, but acknowledgement can be the best medicine we have. It makes things better, even when they can't be made right.
So in closing, one of the things that I want to talk about is wherever you are in your journey, there are going to be good days and there's going to be bad days. There's going to be difficult times and there's going to be amazing times. There's going to be lots of joy and happiness, and there's going to be a lot of sadness. And what I want to tell you is that in the midst of those moments, there are people here who want to help you emphasize making every day the best day they can be. And that's really what palliative care is about. It's about addressing suffering and trying to create space and tools and mechanisms and ways to ensure that suffering is looked at holistically, right from the beginning of the diagnosis of cancer. And so as we think about this together, I just want to say that I'd be happy to answer any questions. I'm so grateful for the opportunity to speak with you. It's a little bit weird to do this pre-recorded, and so I'm really looking forward to kind of the question and answer session and seeing if maybe we can have a good discussion together now. So thank you for this opportunity. More soon.
Thank you so much, Justin, for this presentation. It was lovely. I will pass the floor to Dr. Ana Lacerda just to give a few words.
The screen.
The screen.
The screen. So I vou só agradecer ao Justin e depois direi umas palavras em português. So first, Justin, I just want to thank you for another wonderful presentation. It was really very enriching, and this is for parents, of course, but I was listening to you for the 11th time, and I was thinking our colleagues in oncology really must, they should be here too, because this is for them as well. Eu gosto muito de ouvir o Dr. Justin Baker, espero que também tenham gostado, tenham apreciado, apesar realmente da legendagem automática ter aqui alguns pequenos problemas, mas penso que não terão no geral perturbado muito a vossa compreensão desta apresentação. Eu acho que ele conseguiu tocar e explicar-lhes de uma forma brilhante, realmente porque é que os cuidados paliativos fazem tanta falta a crianças com cancro. Porque efetivamente quando se inicia esta trajetória mais longa ou mais curta de uma criança que é diagnosticada com cancro, o sofrimento está lá desde o início, está lá aquele buraco, aquelas perdas, e que nós temos que saber reconhecer e temos que tentar trabalhar convosco, e agora falo como profissional de saúde, para vos ajudar a fazer este caminho. Uma das coisas que logo no início a tradução automática não fez bem foi explicar a compaixão. E, portanto, para aqueles de vós que não falem inglês, eu queria só realçar aqui que compaixão significa sofrer com. Portanto, é depois o que ele mostra naquele vídeo dos animais em que há o que cai no buraco e há aquele que o vai acompanhar no buraco, enquanto há o outro que está cá em cima só a oferecer a sanduíche. Portanto, quando nós sofremos com, nós descemos ao buraco para acompanhar a pessoa e para estar com ela. Mas é verdade que realmente este sofrimento é sem dúvida uma experiência que é única e que é individual, cada família vai vivê-la de uma forma diferente, até com base naquilo que for a sua história anterior e os recursos que ela própria tem para lidar com as adversidades, até de outra natureza, que não apenas de natureza da saúde. E outra coisa que o Justin abordou, que eu achei muito importante, foi que realmente o diagnóstico do cancro numa criança traz para a família ameaças que são visíveis, são aquelas que é muito fácil nós vermos, que é a doença, os tratamentos, os efeitos secundários dos tratamentos, mas depois também uma série de ameaças invisíveis e que passam muito pelas relações, pela perturbação nas relações entre a família, entre o casal, entre os irmãos, com os amigos, com a restante família, as questões da espiritualidade também tão importantes e que nós muitas vezes ignoramos completamente, passamos por cima. Portanto, sem dúvida que o que os cuidados paliativos trazem para a oncologia é este total care, este cuidado total de que o Justin também falou. Portanto, é estarmos ao vosso lado, a acompanhá-los, ao mesmo tempo que estamos preocupados com o protocolo terapêutico, a cirurgia, a quimioterapia, a molécula, o ensaio clínico, tudo aquilo que nós podemos realmente fazer pelos vossos filhos, mas ao mesmo tempo fazer coisas também convosco enquanto pessoas e com o vosso filho. Aqui em Portugal, o que é que se passa? Nós temos a sorte de Portugal ser um dos poucos países a nível mundial até em que existe legislação que foi publicada em 2018 e que determina que todos os serviços de pediatria devem ter uma equipa de cuidados paliativos pediátricos. Aqui no serviço onde eu trabalho, no IPO de Lisboa, essa equipa na realidade já existe desde 2005. No IPO do Porto há uma equipa também desde 2009. O São João e o Hospital Pediátrico de Coimbra também têm equipas. Não são equipas específicas, porque são serviços de pediatria gerais, portanto não são especificamente para as crianças com cancro. Portanto, eu diria que nós estamos bem no sentido em que todas as 4 unidades de oncologia pediátrica no país têm realmente profissionais dedicados a este tema e que estão lá realmente para ajudar as crianças e as famílias. O problema é que ainda existem muitas barreiras e o Justin também falou um pouco dessas barreiras e a principal é sem dúvida as pessoas acharem ainda que os cuidados paliativos são realmente cuidados de fim de vida. Portanto, eu espero que aqueles de vós que assistem agora em direto ou mais tarde a este webinar realmente ultrapassem esse mito de que os cuidados paliativos são cuidados para quando alguém está muito mal, quando alguém está a morrer. Nada disso. Os cuidados paliativos pediátricos servem exatamente para vos apoiar desde o início, toda a família, nesta trajetória. Eu penso que há uma coisa que os países anglo-saxónicos fazem muito bem, e nos Estados Unidos isso é muito verdade, que é as famílias exigirem coisas. E eu penso que aqueles que estão aqui connosco hoje neste webinar terão com certeza agora ferramentas e um entendimento para exigirem junto dos da vossa equipa na oncologia, exigirem melhor capacidade de comunicação, melhor coordenação e planeamento de cuidados, e partilharem mais as decisões com a equipa e trazerem outros valores para essa tomada de decisões para cima da mesa. É como o Justin disse, é viver melhor cada dia, fazer de cada dia o melhor que esse dia pode ser. Penso que não diria mais nada, não sei se há perguntas para o Justin, com certeza, ou eventualmente para mim também, se eu puder ajudar em alguma coisa, e se quiserem que eu traduza para inglês, eu falo com todo o gosto, eu e a Cristina.
At the moment, we only have a question and a thank you. There's a doctor from IPO do Porto, Silvia Silva, who is thanking Justin for the powerful video you showed. I don't know if you met, probably, I don't know. And then we have a question from João Bragança, who's, I think you've met also. He's the president of Parents Association here in Portugal and also CCI World. So, and he's asking, he's actually saying that this is a very relevant topic for parents' organizations for 2 moments, during the treatment, but also after the child has died, because it's a very difficult period. And sometimes parents' organizations feel that they exist to help parents during treatment period and not after the death of the child. What João is asking is, in your experience, do you think the MDs have properly been trained for this compassion?
Yeah,
we can have both answers, because I think we have different realities.
Yeah, I'll answer both, but does somebody want to simultaneously interpret or after?
Doutora Lacerda,
Justin, you can answer, and then I will try to. I'll do my best.
Perfect.
To translate.
Well, Zhao, thank you so much for the work you do. For those parents that are on here, thank you so much for joining us. And I'm going to answer the easier question, which is the physician one. And then I'm going to also talk to you about what I might recommend to you at CCI and with other parent organizations. So the answer is very easy. Physicians have not been properly trained, and this needs to move into medical school training. But it's not only physicians, really also nurses haven't been trained. When you think about the disciplines that have received training, the ones that probably get the most are some of the psychologists, but it has not been well integrated into medical nor nursing training. And I think it is incredibly important and vital that it be done there. But what we have tried to also encourage is that for those subspecialties like pediatric hematology oncology, where it is just critical to have this as a part of who you are, that there be required communication courses built into subspecialty expectations. And so we're trying to do that, but that I would not say that's gone tremendously successfully. But as you're thinking about things potentially in Portugal, the way to advocate for this is at the medical school level, at the pediatric residency level, all residencies really, and then at the subspecialty level. All three of those levels need advancing amounts of education and training in compassion, but also in communication. And so, Anna, I'll stop there and let you.
Yeah, I was going to ask you that.
Exactly, but I want to come back to the other question as well.
To the CCIE. Ok. Então, o que o Justin respondeu é que realmente não, os médicos não recebem de forma alguma treino adequado, educação adequada sobre comunicação, e isso é verdade também nas outras profissões da saúde, à exceção talvez dos psicólogos, que são aquelas pessoas que realmente logo desde a faculdade aprendem a comunicar melhor. E a opinião dele é que realmente há determinadas áreas da medicina, como é o caso da hemato-oncologia pediátrica, em que este treino de comunicação deveria realmente ser obrigatório. Eu tenho que fazer aqui um pequeno parênteses, o Justin não disse isso, mas aqui há uns meses, e até com o apoio também da FROC, nós fizemos um webinar de treino de comunicação exatamente com a equipa do St. Jude, e penso que temos que repetir, não pode ser uma ocasião única, tem que ser repetida. O Justin disse também que acha que realmente o que é necessário fazer é advogarmos por implementar estes treinos de comunicação nas escolas de saúde, portanto nas faculdades de medicina, nas escolas de enfermagem, etc, por aí fora. Eu devo dizer-vos, vou dizer agora em português e depois vou também dizer isto ao Justin, que na realidade aqui na Europa neste momento existe um movimento para incluir treino de cuidados paliativos, o que incluirá com certeza comunicação na especialidade de pediatria até a nível europeu. Portanto, penso que isto são boas notícias. Justin, I just gave your answer in Portuguese, but I added two things. I spoke about the webinar that your team so kindly did with us a few months ago, with the support from FROC, from Christina as well. And I was saying that this cannot be a one-time occasion. We really should repeat this once in a while. And I was also saying that let's hope that things are changing, because right now there is a movement in Europe to include palliative care training and education in pediatrics residency and subspecialties. So there is a movement at the European level. So let's hope that in the coming years it will become a reality and things will be better.
Oh, that's so encouraging, Anna. Thank you for sharing that with me, and I very much agree with you. So to the second part, which is kind of the involvement of parents, and João, you know better than almost anybody how important and helpful this is. And when I think about parent groups, there really are three groups of parents that are vitally important, and those are parents who can comment or are part of active treatment. There are parents who then are parents of children who survived, and there are parents of children who died. And I think advocacy groups need to realize that there are those three levels and actually work on all three of those levels. And I think it's really vitally important because the needs of each of those parents are different, and the people who can best address those needs are different. And what we've done at St. Jude, for instance, is we've involved parents in everything that we do here at St. Jude. So parents help with navigation of newly diagnosed children with cancer. They help mentor. So we have a mentoring program for patients and families on newly diagnosed with cancer. And these parents walk with them through that time. And then we also have a mentoring program for bereaved parents. And so our bereavement program is built on the backbone of bereaved parents. And this number I'm about to tell you is astounding, but we have more than 50 bereaved parent mentors, and we have about 250 bereaved parents involved in all the programming. So my point in this is simply to say, as you know, parents love to be engaged and involved, and it's so important to allow or to ensure that that we're addressing issues for parents and children on active treatment, also into survivorship, and also in bereavement. And I think that as an advocacy group, CCI in particular, I think that creating really specific tracks, if you don't yet have those in that way, would be really helpful. And that's certainly how we think about them here at St. Jude.
Thank you, Justin. I will try my best. O João Bragança, que é a pessoa que colocou esta pergunta, e um beijinho especial para o João, é o presidente do CCI, que é o Children Cancer International, para quem não saiba, portanto é o grupo internacional de pais de crianças com cancro. E o que o Justin disse é que temos que reconhecer que há 3 grupos distintos de pais que têm necessidades diferentes e que têm que ser respondidas de forma diferente. São os pais das crianças que estão em tratamento, das crianças que sobreviveram ao cancro, que são sobreviventes a longo prazo, e os pais enlutados. E a forma como o Justin acha que nós podemos também ajudar os pais é deixá-los ajudar-nos a nós. E ele disse-nos que a experiência dele no St. Jude é que os pais destes 3 grupos ficam sempre muito felizes de poder ajudar o programa. Então, e de que forma é que ajudam a equipa no St. Jude? Envolvendo-se sobretudo em programas de treino. Os pais ajudam muito os médicos mais novos a fazer treino de comunicação, treino de planeamento de cuidados, mas ajudam também outros pais. E o Justin contou-nos que, por exemplo, o programa de luto da sua equipa é baseado em pais, portanto são pais que apoiam outros pais, e que tem 50 pais enlutados que são mentores de cerca de 250 pais em luto que estão permanentemente incluídos neste programa. Portanto, sem dúvida que são necessidades diferentes, respostas que são diferentes, mas podemos com certeza envolver todos estes pais no trabalho diário e na melhoria contínua dos cuidados às crianças com cancro. I did my best, Justin.
I think you passed the right message.
One of the things that I would like to pass on about that as well, and this is for, I see there are some doctors on here, but at the advocate level as well, when we started these programs, we started them in about 2011. And when we started the program, the hospital leadership and in particular, kind of the legal team said, oh, please don't do this. This is a bad idea. This is going to cause problems. We want to make sure that we're doing right by the parents. And I had, because I had spoken to so many bereaved parents, I knew that wasn't true. But there were real concerns that we would hurt parents by involving them in this way. And I want to tell you the opposite is true. We hurt parents by not having them involved in these ways, by not allowing them to have opportunities to give back in this way or be engaged. We both, diminish their experience. We don't give them a chance to help give back. And also this giving back is tremendously healing. Like it is just, the parents that do this work with us, we have parents involved in teaching communication for our clinicians. We have parents involved in teaching our nurses how to do bedside care. We have parents involved in our entire bereavement program. Like I said, each time that they give back, they say, oh, that was really hard, that was difficult, but they say it's a good hard. They say it's like working out, that it hurts while they're doing it, and at the same time, they know they're much better because of it. And it takes them one step further kind of in this process, this journey that they're on in this either grief and bereavement or in their treatment journey.
Ok. Portanto, o Justin quis comentar um pouco mais sobre isto e contou-nos agora que este programa de envolvimento dos pais no St. Jude começou em 2011 e que na altura a administração do hospital achou que era uma má ideia, porque era preciso ter muito cuidado, porque provavelmente se iria causar mais sofrimento aos pais. E o Justin insistiu muito, que não concordava nada com isso, e a experiência deu-lhe razão. E o que nos disse é que realmente o que causa sofrimento aos pais é não lhes permitir envolverem-se, a não lhes darem oportunidades para se envolverem nesta melhoria contínua da qualidade dos cuidados prestados pela equipa. Portanto, os pais no St. Jude realmente estão envolvidos em treinos de comunicação, em treinos dos cuidados diários até com as enfermeiras, os treinos, os programas de luto, como já falámos, tanto com outros pais como com profissionais de saúde, e realmente a experiência do Justin e da sua equipa é que permitir aos pais envolverem-se é mais uma ajuda, é mais uma ajuda para nesta viagem que é feita um passo de cada vez ao longo da trajetória da doença. My best again.
Now there's a question for Ana Lacerda by also João. And I will ask in Portuguese. Haveria abertura em Portugal para os pais ajudarem os médicos?
João, da minha parte toda, mas eu não posso responder pelos diretores dos serviços. Eu penso que tem que passar pelos diretores dos serviços, são as primeiras pessoas a cativar com certeza para esse envolvimento. Eu penso que há uma história que a acreditar, não é? Da qual o João é presidente, tem em Portugal de trabalho com os serviços, e eu julgo que é fazível. Poderá haver algumas caretas ao princípio, mas é fazível e lá está. Eu acho que a nossa sociedade também tem que evoluir e, para mim, este envolvimento dos pais penso que é fundamental também. E ao longo dos anos em que tenho sido oncologista pediátrica, sem dúvida que das experiências mais felizes, não se sentam ofendidos com isso, mas as experiências mais retributivas da minha vida têm sido realmente no trabalho com pais. Acho que quando nós conseguimos interagir é fantástico.
Just for Justin to understand what was being said, João asked if the doctors here in Portugal would be available to have the parents helping the doctors in doing such a program on like you have in St. Jude's. And Dr. Ana Lacerda said this is a question that they would have to speak with the directors of the services here in Portugal, but for her, she thinks
it's a no-brainer.
No-brainer.
It's a no-brainer.
Yeah.
I think we have some experiences here, but we have to go further. We do have to go further.
Maybe the last comment I'll make on this particular question is, you kind of have to set some parameters, because what I did at the beginning was create pretty small scale activities, and I would walk very closely with each parent through that, and we had a very close relationship. But as we've gotten bigger and bigger, what we've really had to do is invite them in as true partners. And in that partner, when I think about partnership, I think about them being a part of the planning committee, them being a part of creating the actual educational content, and certainly them being a part of understanding what the script is or what the hope is as far as asking. Because sometimes when I see families get involved, I see them asking to be involved mostly in like just telling their story. We really want them to be involved in all the content development and the actual really significant delivery of this. So the temptation, my point in this is the temptation at the beginning is to just be like, oh, good, we took that to the parents and they were kind of, part of the process, but we're kind of right at the very end. We've found that the way to really involve parents has been to make them a part of things right from the very beginning with us, with strategic initiatives, with educational planning development, all along the way, including debriefing after these events.
O que o Justin comentou agora foi, no fundo, alguns conselhos, se nós realmente quisermos dar este passo aqui em Portugal e envolver mais os pais no trabalho com a equipa e com outros pais, e basicamente a mensagem é que não podemos simplesmente ficar muito satisfeitos porque conseguimos pôr um visto feito no envolvemos os pais, mas temos realmente que envolver os pais desde o início, no desenho, na estratégia, na implementação destes programas, para que realmente vão ao encontro daquilo que são as necessidades tanto da equipa como dos pais, porque senão realmente o risco que corremos é do programa não servir para nada, outro de causarmos mais sofrimento aos pais. Portanto, é preciso trabalharmos com os pais desde o início no desenho destes programas.
I have probably one last question if no one else has. And this is more about the Portuguese reality. So it will be for Doutora Ana Lacerda, but what I would like to know is like a parent that just had their kid newly diagnosed and is watching this webinar, and he really wants that the treatment will be with a great quality, or he will be concerned about the quality of life of the kid. What should be their next steps? You know, who should they speak with? How does it work to get into a palliative care team to speak with them? Eu só posso, se calhar, repetir a pergunta em português. Só dizer, estava a perguntar à doutora Ana Lacerda o enquadramento de um pai com uma criança acabada com um diagnóstico recente, que esteja a ouvir este seminário, saber como é que tem acesso então a esta equipa que hoje está presente nos vários hospitais.
É falar com o seu médico assistente e pedir para ser referenciada à equipa. É como funciona. Infelizmente, eu penso que aquilo que se passa na equipa do IPO de Lisboa é o que se passará também nas outras, é que a referenciação à equipa é feita só a pedido e, portanto, terá que ser o médico assistente ou a família a pedir para ser feita essa referenciação. Mas a partir do momento em que isso é feito, haverá uma preocupação adicional com todos estes aspectos relacionados não só com o tratamento da doença, mas também com a qualidade de vida da criança e da família.
O push pode ser feito também pelo lado dos pais, também é um bocadinho esta...
Pode, com certeza, foi isso, exatamente.
Pois.
Era essa também era uma das mensagens que eu tinha aqui para transmitir, é que realmente penso que, e nisso realmente os americanos são muito bons, é as famílias empurrarem também desse lado, não é? Ou puxarem desse lado e dizerem, nós precisamos disto, nós queremos isto, nós valorizamos isto e percebemos a importância disto. E por isso, obrigada à FROC por dinamizar este webinar, porque realmente temos ainda em Portugal muita pedra para partir em relação aos cuidados paliativos e a desmistificar os cuidados paliativos também em oncologia pediátrica.
I don't know, Justin, if you want to say a few words, we are just wrapping up. Dr. Ana Lacerda was just wrapping up, just saying how important this conversation is, and to talk about palliative care is important, just so that the parents know if the palliative care is not, that they can do the push of the service, right. And so this is...
Yeah, I was saying they can push for the service, they can demand, they can demand.
Right. That's right.
You're empowering them.
That's right. I think there are two things that I want to get across. Number one, palliative care is an entire approach to care where we address suffering, and we try to address it in the ways you heard me talk about. The second is that we are about promoting quality of life. So we're against suffering and we're for quality of life. And that's why, I hold this koala bear. And so if you ask any family, they're going to say, yes, I want less suffering and I want more quality of life. And so integrating palliative care and trying to bring that approach in, the main barrier to that are medical establishment barriers. They're not family barriers. They're usually barriers with how teams work together. And so as parents, you absolutely should be advocating for the best quality of life for your children and to address suffering in all the ways possible. And palliative care can be a really effective way to do that. I've got to jump off, but I thank you guys so much for the opportunity to be here with you all.
Thank you so much, Justin. Doutora Lacerda,
Adeus. Bye.
Quer traduzir aqui as palavras finais?
Pronto, acho que foi uma oportunidade única termos aqui o Justin connosco e espero que tenham gostado do webinar e que tenham realmente percebido que os cuidados paliativos pediátricos estão aqui para vos ajudar desde o início e com certeza ao longo de toda a trajetória, se infelizmente o resultado não for aquele que todos nós desejamos, mas a verdade é que nós queremos estar desde o início ao vosso lado. É isso. E obrigada à Cristina e à Fundação Rui Osório de Castro.
O Justin também reforçou um bocadinho a mensagem que a doutora Lacerda já tinha dito, que aqui os pais também podem fazer o push da coisa e que realmente a qualidade de vida é importante e é fundamental durante este percurso. Bem, vou então, infelizmente até já passámos o tempo aqui do nosso webinar, mas se tiverem alguma pergunta, mas penso que não deixámos nada por responder, mas se tiverem podem sempre enviar para o info@frog.pt que nós fazemos chegar aos nossos convidados. A quem portanto, agradeço novamente à doutora Ana Lacerda ao ter-se disponibilizado a estar aqui a fazer este papel às vezes ingrato também de tradução, que às vezes é difícil em simultâneo, e também ao Justin que já não está, mas que foi realmente, acho que é um privilégio poder tê-lo aqui nesta conversa. A quem está do outro lado também obrigada por terem estado connosco. Estas conversas vão ficar gravadas, vão estar no nosso site e também no YouTube. Espero que tenham gostado e que se inscrevam nas próximas sessões. A próxima vai ser em novembro e vamos divulgar em breve nas redes e no nosso site. Obrigada, estejam atentos e até lá.